I will start first of all by saying thank you to the organizers for inviting me. I'm really pleased to be here. So I'll go ahead to share my screen. Please, can you see my screen now? All right, thank you very much and good afternoon to everybody. And to start with, did you know that in the year 2020, 30% pregnant women reported that they felt unsafe at work? And did you know that in that same year, 59% pregnant women had reported to their employers that they feel unsafe and had concerns at work, and yet 17% of these women stated that their employers took no action to address their concerns. So today, I will be talking about protecting every pregnancy and rethinking work conditions for equity. To do this, I will first of all share or throw light on the data about work and also some evidence relating to work conditions and some reflections for all of us to take home as we find solutions to the disparities that we recognize when it comes to maternal and newborn health in the UK. So in the year 2020, the WHO reported that 13.4 million babies were born before 37 completed weeks. Of these, 1.1 million of these babies did not live to celebrate their 5th birthday, which makes preterm birth the leading cause of under 5 mortality. Okay, so again, looking at the data, in the world globally, in 2023, the year 2023, 32 million babies were born. Of these, about 10% were preterm and 14.7% were low birth weight. That is birth weight below 2.5 kilograms. In Europe, almost 4 million babies were born in that same year, and 6.9% were preterm, 7% were low birth weight. Coming home to the UK, about 688.388 thousand babies were born in the UK in that same year, and 7.9% were preterm, while 7.2% were low birth weight. Looking at the data in terms of rates of adverse pregnancy outcomes by ethnicity, just like the other disparities, stillbirth risk was higher in ethnic minority women as compared to their white counterparts, and also preterm birth, as well as fetal growth restrictions. And so this indicates that all these disparities, all these adverse outcomes are higher in ethnic minority women compared to their white counterparts. We already know some risk factors when it comes to some of these adverse pregnancy outcomes, i.e. infections, maternal age, that is adolescent pregnancy between 15 to 19 years, as well as advanced age above or equal to 35 years. We sometimes have provider-initiated low birth weight as well as preterm, because there could be an underlying maternal or fetal conditions that necessitate that pregnancy needs to be terminated. And in also situations with multiple or twin pregnancies can also predispose to preterm birth or low birth weight, as well as smoking. So these factors, these predisposing factors are known that we can link them to some of these adverse pregnancies. However, in about 45 to 50% of preterm or spontaneous preterm birth and low birth weight, the causes are not known. We don't know what is causing. None of these non-predisposing factors can be identified in these spontaneous preterm birth. So the question is, how do we resolve them? How do we manage conditions or things that we do not know? So in our quest to find answers to some of these, we set out to address two aims. One was to investigate the association between maternal work or maternal handling, lifting at work, and adverse pregnancy outcomes. And also, the second aim was to identify or examine the association between duration of maternity leave and adverse outcomes at the country level. To address the two aims, we used the first aim, the source data was the Finnish Medical Birth Register between 1997 and 2014. And so in that data, all singleton births of mothers that were classified as service and care workers were classified as the high exposure group. And there were a total of 74,286 women. And for those who were classified as low exposure group, they were mainly clerks. So for the high exposure group, they were occupations including nurses, healthcare assistants, kitchen assistants, and all those were classified as service and care workers. So they were in the high exposure group. And then the clerks were secretaries, bookkeepers, work that were more sedentary, and they were classified as the low exposure group. And the number was 13,873. For the second aim, that is to look at the association between maternity leave and birth outcomes, we identified the data from the ILO 2014. And then for the income data, we also got it from the World Bank between 2007 and 2013. And these were from 174 countries. The results, when we did the analysis using these source data, we identified that for the high exposure group, that is for the aim number one, for the high exposure group, the odds of having a preterm birth was 16% higher among women who were highly exposed at work to do manual handling as compared to the low exposure group. And for low birth weight, the odds was 12% higher among the higher exposure group compared to the low exposure group. And for perinatal death, the odds of having a perinatal death was higher, 51% higher in the exposure group compared to the low exposure group. So that was for the first aim. That is the association between manual handling of burdens and adverse pregnancy outcomes. And that was published in the Scandinavian Journal of Public Health at the time. So looking at the second aim, we use the data from the International Labour Organization and the World Bank and look at maternity leave and association between that and pregnancy outcomes. We identified that given an additional 1 week additional maternity leave could have reduced or was associated with 0.09% lower preterm birth. So to use that in calculating using the global incidence or prevalence of preterm birth, we can say that given an additional 1 week maternity leave could have reduced preterm birth globally by a little over 12,000. And again, an additional week of maternity leave was also associated with 0.14% of low birth weight. Again, using that to do the same calculation, we could have reduced low birth weight by 28% by giving an additional maternity leave, according to that data. Within countries, 36 countries that specify their prenatal maternity leave, that is giving maternity leave, which was mandatory to be taken by pregnant women before they give birth. It was identified that given an additional prenatal maternity leave, 1 week was associated 0.07% lower preterm birth, and also 0.09% less low birth weight as compared to giving not even that at all. So again, that publication or that study was published in the Scandinavian Journal of Public Health. Going forward, I want us to look at what does the data say in terms of work and working conditions for especially ethnic minority women. There is an evidence of ethnic minority women having negative career experiences in the UK. And so when we look at the TUC data report in 2020, it was reported that 12.1% of BME women reported that they are insecurely employed. They were insecurely employed compared to 6.4% white women. And again, when we look at another data by Carmichael and Woods in 2010, minoritized women have higher representation and in physically demanding occupations such as caring jobs, cleaning, and other jobs that are more exposes them to manual handling, long standing hours of standing at work, and also physical strain. They also have greater fear of reporting or fear of job loss because of structural marginality. And so most of the time, ethnic minority women have the fear of losing their jobs because they feel when they complain, when they talk about whatever challenges they are going through at work, they might lose their job. And so where there are no mandatory restrictions, pregnant women or employees of ethnic minority background may find it difficult to talk about the concerns that they have at work. And so they rather keep quiet to save their jobs rather than to speak to protect their pregnancies. And so the question is, what can we do to make everybody feel safe, to make everybody capable and also feel okay to talk about their concerns at work knowing this evidence, knowing that there could be a link between working conditions and pregnancy outcomes. So to bring my presentation to an end, I want us to reflect on these questions as we go along to identify solutions to the disparities that we see in terms of maternal and newborn health within the UK. So the question is, and what I want us to reflect on, is that why are ethnic minority women overrepresented in physically demanding jobs? And why do we continue to accept this as normal? Could it be that there is a silent link between what is happening at the labor or at the employment work area and the numbers that we are seeing in our labor wards? What will be a truly equitable workplace look like? How would it look like? And what is it that we can do to reduce or to make it more equitable, to protect some of these women, to make sure or to see if the numbers we see in terms of adverse pregnancy outcomes being reduced by what the solutions or the conditions we put in place for these women at work. And so it's more of an advocacy, it's more of highlighting what is there in terms of the data and evidence, and trying to bring all our attention to the fact that something has to be done, especially if we want to address the disparities that we are witnessing within our setting in terms of preterm birth, low birth weight, and also all the other things that comes with maternal and newborn health. So that brings me to the end of my presentation, and I thank you very much for your attention.
Thank you ever so much, Emma. That was really fascinating, really interesting stuff. I think it's going to generate some questions. Some have appeared in the chat already, and I'll bring those up at the end. If you do have questions, please put them in the Q&A or the chat. The Q&A is probably easier because we can pick them up a bit easier from there, but either way, that's fine. So thank you ever so much for that, Emma. That was really good. That gets us off to a cracking start, but we're now going to change tack slightly, and I want to introduce our next speaker, who's Dr. Jasmine Hearn, who's a senior lecturer at Manchester Metropolitan University. Jasmine's interest is in endometriosis, which has huge relevance to pregnancy and beyond, as well as to the general health of women. So it'll be really interesting to see how her work fits with Emma's. So I'm just going to hand over straight to Jasmine, if that's all right, and your talk. Thank you so much.
Great, thank you, Richard, and thank you everybody for inviting me. Let me just organize my slides a little bit. Hopefully they're coming through on the big full screen now. Yeah, thank you. I'm really glad to be involved in this series of webinars. I think that we're showcasing some really important issues over the next few weeks. I'm Jasmine Hearn. I'm a psychologist and senior lecturer based at Manchester Metropolitan University, with an interest in chronic pain really broadly, but also specifically in relation to women's health issues, such as painful periods and more specifically conditions like endometriosis. So today I'm going to talk a little bit about a piece of work that was published last year where we aim to understand the sort of barriers and facilitators to getting diagnosed and getting appropriate support for people with endometriosis. And I'm going to talk a little bit about our next steps in terms of research, but also priorities and recommendations for the healthcare system as well. So to start us off, endometriosis, for those who might not be familiar with it, is a chronic progressive inflammatory condition that's rooted in immune dysfunction. And it's characterized by the presence of endometrial-like tissue that grows outside of the uterus, so in areas where it's not supposed to grow in. Those growths cause inflammation and irritation, and can be more or less widespread. They can grow to sort of different extents, different depths within organs, within tissue, and that inflammation and irritation tends to cause chronic pain. Now, endometriosis tends to be localized, but it can also be found elsewhere in the body, often in the bladder or the bowel, but it has been found in other areas of the body as well. So whilst it's considered a gynecological condition, actually it's being understood more and more as a full body disease now, as rather than gynecological only. There's lots of symptoms which I'll come back to in a moment. The biggest ones being, or the most common ones being chronic pain, heavy painful periods, bladder and bowel problems, fatigue, and difficulty conceiving. They're often related to the menstrual cycle and may fluctuate according to hormonal fluctuations. So some people might have pain that fluctuates throughout their cycle. It might be more intense on some days and less intense on others, but actually for a lot of people it might also not be cyclical in that way. It might be fairly constant. So it's quite individual depending on the extent of the disease in the individual who has it. It's surprisingly common, more common than we might expect. It affects around 10% of women globally. And if we look at the Manchester and Greater Manchester population, that equates to around 17,000 people in Manchester City and 70,000 in Greater Manchester. So it's a really big population, similar proportions to people who have diabetes, just to sort of draw that parallel so we can get a sense of how common it is. Unfortunately, because, or for lots of reasons, the symptoms can be quite vague, quite non-specific, quite difficult to understand. They might fluctuate, like I say, according to the menstrual cycle. Unfortunately, people can go through lots of misdiagnoses and diagnosis delays. Often people may be diagnosed with things like IBS because of sort of overlapping symptoms. The most recent estimate last year was that people were waiting on average over 8 years and 10 months for a diagnosis from the start of their symptoms. So really long delays, and that's a really important point to make because endometriosis is progressive, and if people are having those kind of delays, then it may be that it's getting more and more widespread, it's growing more deeply within tissue, it might be more tricky to try to manage and treat it. So a real priority is getting that diagnosis delayed down. Just in case there's people in the audience who like to have a bit of a visual, this is what endometriosis might look like for some people, just to illustrate where the growths might be if we're looking at the uterus or the pelvic area. So the endometrial tissue would grow inside the uterus, but in endometriosis we might find it outside of the uterus. So it might be on the fallopian tubes or on the ovaries or in the bladder, bowel areas, in the lower intestines. So hopefully that just sort of brings that to life a little bit if you're not so familiar with what endometriosis is or how it might sort of manifest in the body. So here are some of the signs and symptoms of endometriosis. I'm not going to walk through those now, but what I will focus on just very briefly is the diagnosis process and the treatment options that people have. So the gold standard for diagnosing endometriosis is through laparoscopic surgery, which is obviously fairly invasive and not a lot of people might want to go through those kinds of surgeries to be diagnosed, but it is the main way to diagnose it. It's also the main way to treat and remove endometrial growths. So where endometriosis is found, it can be sort of cut out of the body, sort of excised, removed, as a form of treatment. For some people that does work and can reduce the symptoms, can address it, but then for others the endometriosis may grow back. So there are other options available, hormonal treatments that will sort of disrupt the normal hormonal fluctuations and sort of bring them into a little bit more of a balance to reduce the symptoms. pain relief, so pain medications, and for some people, complementary therapy. For a lot of people, these may work, but there are some small proportions of people for whom these approaches do not always work, which is another challenge. In 2018, 2019, the All-Party Parliamentary Group on Endometriosis worked with Endometriosis UK to do a big survey of people with endometriosis about their experience of getting diagnosed. And these are just some of the key stats that came out from that survey. Ones that I just want to bring your attention to specifically are the large proportions, 58% or so of people going to their GP multiple times, 10 or more times before they got diagnosed. Lots of people going to A&E because their pain has been so intense that they felt that's the place that they need to go for that in terms of getting urgent treatment. And large portions of people wanting things like psychological support, pain management support, but not being offered it. And that's quite important for the purpose of the work that I'm going to talk about, just because whilst these are challenges, we've aimed to try to develop as comprehensive as possible understanding of the barriers, the challenges, but also the facilitators that people with endometriosis experience in terms of getting diagnosed. And we do that from a behavioural perspective, which I will talk about now. So within health psychology, which is my background, we use frameworks and theoretical models to try to understand behaviour, and in this context, really understanding what drives or prevents people with endometriosis from reaching out, from seeking help for their symptoms, whether it's to get a diagnosis, to get pain management, or whatever's important to them. So we aimed to use a comprehensive model of how we understand behaviour, in this case the COM-B model, to try to understand all the possible influences and determinants of the target behaviour, which is that help-seeking behaviour. So the COM-B model understands behaviour as driven by our capability, so whether we have the skills and the knowledge to engage in the behaviour, we have the confidence, we know how to discuss our symptoms, we know maybe medical jargon for it, for example, and we know where to go to get the help that we need. Opportunity, which is the sort of broader social and environmental influences on a behaviour, so whether I've got the social support to engage in this, whether it's what other people would do, is it the sort of normal thing to do to talk about these kinds of issues, that kind of thing. And then motivation, which is the willingness to engage in it, which is often tied into people's emotions about an issue. So whether they feel like they're going to be believed, whether they're actually motivated to, or they think that they're actually going to get the help at the end of it. So we use this model, and this is just an illustration of how that model looks again, with the kinds of questions that people might ask themselves. So we use that model to try to understand all of these factors that might influence people when it comes to seeking help. And we did this with a qualitative study where we did some interviews, and we did a large online survey where we got people who were diagnosed and also in the process of getting a diagnosis to tell us about all of those kinds of factors that related to their capability, opportunity, and motivation, to understand how each of these factors influence their experiences of getting diagnosed or getting help for their symptoms. So what we'd found, and I apologise, it's not the prettiest diagram, but I'm going to talk you through each of these components in turn. I'm actually going to start you at the bottom where the opportunity component is, and that's because the opportunity was where the biggest sort of barriers and issues and challenges came through in that work. So this is around whether people feel like they have the access to the resources, the support, the time to go and get help. And I'll give you a few examples of what people said in a moment too. So for opportunity, the big story, which is maybe not going to be surprising to those of you in the audience, that there was felt to be a lot of sort of stigma around how we talk about women's health, how we talk about periods, how we talk about blood, how we talk about endometriosis, and those kinds of issues being issues that we deal with sort of quietly and privately. So that was one of those things that kind of stopped people from wanting to talk about it. Experiences of misogyny, unfortunately, people feeling like they were not being prioritized, not being believed, and therefore feeling like they had to sort of suffer in silence because they weren't going to get the help that they wanted. But then more broadly, people would talk about not being able to get time off work to go to appointments, or having surgeries scheduled that they were only given 1 week off of work to recover from, but actually maybe they needed a little bit more time to recover. Not being able to talk to managers about their symptoms and asking for reasonable adjustments at work to manage symptoms, that kind of thing. And then the cost of private healthcare was a challenge for a lot of people. So people tend to see private healthcare as an easier route to get diagnosed because there are shorter waiting lists. But obviously the cost is not something that everybody is able to afford. So that became a challenge for a lot of people. So that was the opportunity. I'm going to bring you back up to the red with the capability component now. And this was really centered on people having had so many experiences where they were reporting them, they were going and asking for help, but were, say, misdiagnosed, or were often told this is what periods are supposed to be like, they're supposed to be painful. Lots of stories of people being given painkillers or hormonal contraceptive pill, which may well treat some of the symptoms, but without getting that diagnosis and that real validation of the symptoms and the experience that they had. So all of that fed into people feeling like they didn't believe their own symptoms, that they weren't actually as bad as maybe they were making them out to be, and that they were normal. So that sort of psychological issue of not feeling confident in their own experiences. And then physically, exhaustion from trying to manage the symptoms, people not being able to get out of bed, exhausted from trying to advocate for themselves so consistently and not having that broader support to do so. And then also sometimes the knowledge of whether the symptoms were actually as bad as they thought they were, or whether they were normal or not. And then lastly, into the motivation component, everything from the opportunity, the capability components kind of fed into that motivation. So really it was a lot of those past experiences informing their future expectations. So where they'd had those negative experiences or been misdiagnosed, they had these future expectations that's what it's going to be like if I go and seek help again. So people ended up thinking that actually it's not a good idea. I'm probably not going to get the help that I want because this has been my experience up until this point. And that was also characterized by lots of anxiety, mistrust, maybe embarrassment that prevented people from going and seeking help. There were people who had more positive experiences, who felt really empowered by their diagnosis and felt really confident to talk about it. But that wasn't very common in the data that we had, and it tended to be from people who were, so for example, we had a participant who was educated to PhD level and understood medical jargon and felt like she could have those kinds of conversations in a really confident way, but it was very much characterized by these kinds of the barriers. So just to very quickly illustrate, because I'm conscious of time, just to illustrate, so that capability, as I've just talked through, people feeling helpless, feeling overwhelmed, not knowing what to do to manage their pain because it was just so intense that the treatment options that they had weren't working, and so they just kind of given up. And then people losing or having impacted social life or relationships because of the pain and exhaustion, and missing appointments because they couldn't get out of bed. Opportunity was really, like I said, around that sort of taboo, the stigma, the sort of minimisation of painful periods and women's health issues that meant that people couldn't talk about it openly. Private healthcare and the cost being a barrier there, and then not being able to get time off for work. And then lastly, in the motivation. So again, there's the sort of negative experiences of going through this sort of trial and error process, not having a clear pathway, treatment options not always working, meaning that people just didn't feel confident in the treatment or care that they might receive. So in terms of next steps and sort of priorities, when we use things like the COM-B model, this allows us to more comprehensively develop interventions that address those key issues and in a way that is informed by theory and allows us to use specific techniques to overcome those challenges. So part of our next steps is to look at how we develop capability, opportunity and motivation for both people with endometriosis, but also broadly within the healthcare system. And that starts off with understanding more thoroughly the experiences that health professionals have in relation to working with, supporting, diagnosing, treating people with or with suspected endometriosis, and all of the wider systemic healthcare barriers that there might be that we don't have a thorough understanding of yet. And that might even start with going back to medical school training and looking at how we might embed more of this kind of awareness and training from the outset, even before medical students go into specialising in their training, at least giving them a foundation knowledge of these kinds of issues. There's also work to be done around workplace awareness and policies to enable people to go to appointments and to have reasonable adjustments and so on. And then more prioritisation, of these kinds of issues by providing clear diagnosis and treatment referral pathways, but which we do have, but with more of a multidisciplinary lens to it. So going beyond the sort of medical treatment and offering as a standard more of that kind of psychological support as well. So in terms of future directions, what we're aiming to do at Manchester Met is look at how we can best manage and communicate about endometriosis, focusing on training health professionals and developing guidance for pain management that, like I say, goes beyond that medical treatment on its own. We're working on quite a lot of policy engagement. I'm going to an event next week on Monday in Parliament where we're talking about a loneliness initiative, but I'll be focusing on the impact of endometriosis on people's experiences of isolation, and hopefully long-term moving towards a model for supporting endometriosis management and diagnosis. And I'm going to end there. Thank you very much for listening.
Thank you ever so much, Jasmine. Again, really interesting, really loads of stuff there that we could talk about, and there are already some questions coming up in the chat, which I'll consolidate and we'll talk about afterwards. So thank you ever so much, really interesting. In the interest of time, I'm going to just move on now to introduce Kylie Watson, Dr. Kylie Watson, who is a midwife consultant at St Mary's Hospital and a lecturer at the University of Manchester. Kylie's interest is really in the postnatal period, which brings a different aspect to reproductive and health, and she's going to talk a little bit about that and factors that influence the healthy lifestyle in the postnatal period. So I'll let you explain everything else, Kylie, as you go, but really welcome to you, and the floor is yours.
Thanks very much, Richard, and thanks for inviting me. I hope you can see that slide now okay. So my name's Kylie Watson. As Richard said, I'm a consultant midwife at Manchester University, and I've got a fairly short presentation about some work that we're actually planning. It's not been done yet, but we think it's a really important topic. So it's a collaboration between myself and Dr. Christine Ferber, who's at the Salford University, who's a professor of midwifery there, and Bethan McAvoy, who works with me as a clinical midwifery research fellow at MFT. And this is some work that's been funded by the local maternity and neonatal system, and I'm going to talk to you about some of the drivers for that as well. So in terms of background, this work is around obesity and healthy weight management following a pregnancy. But as you can see from the slides, and I'm sure everyone is aware, obesity is increasing and has increased year on year for the past 3-4 decades. The left-hand side there is severe obesity, women in the red and men in blue. And the slide on the right shows the link between obesity and deprivation, with around 39.5% of women living in the most deprived areas of the country being obese. In terms of the impact of obesity on maternity outcomes, there's a direct association between pre-pregnancy obesity and poor perinatal outcomes, and that's been quite well evidenced for a number of years as well. And if we think about the slide on the left there is from the Embrace report, which looks at maternal mortality in the UK. They publish a report every 3 years looking at really in depth the number of women that have died over the 3-year period. So between 2020 and 2022, 275 women died during pregnancy or up to 6 weeks after pregnancy. And of those women, 37% of the women who died were obese, and a further 27% were overweight. And there's also links therein with Emma's talk about the inequalities in terms of ethnicity and maternal mortality as well, and deprivation. And maternal obesity is associated with a number of complications of pregnancy. Women have increased risk of miscarriage, stillbirth, hypertensive diseases such as preeclampsia, diabetes, and a number of other complications that are listed there. And a recent report also from the Manchester Child Death Overview Panel, which looks at all childhood deaths up to 1 year within Manchester. They analysed 55 childhood deaths, and across all categories of death, maternal obesity was identified as the most common modifiable factor. So it's all really, really interlinked. There's some work done in 2010, a large piece of work that analysed data from 34 maternity units, looking at over 600,000 births, and there was an increased odds of being obese with increasing age, parity of Black ethnicity and deprivation. And so there's this real link with health inequalities and maternal obesity, and more research required within this area. So the Greater Manchester and Eastern Cheshire Local Maternity and Neonatal System, which kind of oversees the 7 trusts within GMAC and the 9 maternity providers, have this Equity and Equality Action Plan that was published in 2022. And within that, one of the interventions, it was a very, very large document with a large number of interventions and actions. One of these was around addressing high body mass index within the pregnant population, with an identification that in Manchester, the rates of obesity are higher than the national average. And at the time of booking, so women booking for their pregnancy, the rates of women being overweight or obese is approaching around 50%. Apologies if that's a little bit tricky to read, but these are just all of the actions that are within that Equity Action Plan around BMI, and particularly understanding our demographics more in Manchester in relation to raised BMI and other demographic demographic things such as ethnicity and IMD, looking at improving all healthcare professionals' knowledge around some of the community assets that might be around to support healthy weight and lifestyle, and a number of other things, actions around developing more routine preconception care for women with a raised BMI, working with our voluntary organisations within the community more closely, and a number of those other issues there. So a really big ask and a big piece of work. This strategy goes up to 2027. So we've been looking at a lot of the actions for the last couple of years, and the local maternity and neonatal system put out a call and have funded this small piece of work that I'm going to talk to you about in a minute. In terms of the evidence, there's a wide variety of evidence across different interventions within pregnancy and in the postnatal period, but a large systematic review identified that antenatal dietary and lifestyle interventions for pregnant women who are overweight or obese alone or in a combination with pharmacological agents are insufficient really to limit gestational weight gain in the degree required to have a meaningful impact, and that preventing obesity in women of reproductive age before conception and between pregnancies is probably where the focus needs to be. And overall reviews conclude that there are some postnatal interventions which are successful. The literature is across a number of different countries, but the suggestion that those interventions that combine diet and physical activity with an element of supervision or professional support are the most effective. There's a recognition that this is a public health and political issue as well, and not necessarily, an individual problem. We think about food advertising standards, price of fresh food, then it's a much larger problem than at the individual level. National guidance recommends that women with a raised BMI are supported to lose weight in the postnatal period and have some good counselling around contraception and pregnancy planning. But postnatal care has been historically underfunded, and there's a real limited focus in primary care on that postnatal examination being focused on the woman. And the gold standard is that the woman has a separate postnatal appointment for herself and one for her baby, but they're often combined together. There's also a recommendation that there's some disparity amongst commissioning and delivery of contraception services for women as well. So in terms of the work that we're planning on doing, we'd like to better understand the demographic, health and social characteristics of women that have had a baby, that have accessed maternity care from St Mary's Hospital and also wider GM. St Mary's Hospital cares for about 50% of the women within the local maternity system, and look if there are any relationships with maternal BMI, and then explore the barriers and facilitators to healthy pregnancy planning, including contraception access and choice and achieving a healthy weight in the postnatal period. We've got 3 work packages. So the first one, which we're just about to start, is we've got a large data set from the Clinical Data Science Unit within MFT, which is using routinely collected data within our electronic patient record, EPIC. And so we're going to analyse that cohort and look at the demographics in relation to BMI of the women within have had their babies at St Mary's over the last 2.5 years. And look at any links that we can find there and any interesting findings around demographics and geography. The second work package is an anonymous online questionnaire to understand barriers and facilitators to healthy pregnancy planning, and that includes contraception access and choices and plans for achieving a healthy weight. So we're asking questions around before they came pregnant, did women seek any support to plan for the pregnancy? Where did they access that information from and how? Questions specifically on advice and support about having a healthy weight and lifestyle before pregnancy. And then thinking about them in the postnatal period, how well informed do they feel about contraception access and support for achieving healthy weight and planning for another pregnancy if that's what they are thinking about. And then we're going to do some qualitative work interviewing a diverse cohort of women with a BMI over 25 to explore some of those factors more in depth. And we'll use some of the findings from the questionnaire to develop that qualitative work. And then we're going to synthesize that data all together and look at designing some potential interventions for the woman of Manchester to test. So we've just received our ethical approval, and we'll be recruiting towards the end of the year, and hopefully come back next year and report on our findings. So thank you very much.
Thank you so much, Kylie. That was excellent and really brings fantastic conclusion to 3 really, really good talks. I'm very conscious of time. It's 5 to 1. We did sort of promise we'd try and finish by 1, and lots of us got clinical commitments this afternoon to try and get to. Jasmine, I'm really grateful because you've actually answered quite a lot of questions in the chat. So you've been doing your bit in the background. I just had one very quick question for Jasmine that had come up that I just wanted to ask, and then I'll focus on the other 2. Jasmine, how do your findings compare to other chronic pain conditions? Has there been similar work done in chronic pancreatitis or other arthritis or other chronic pain conditions? And is endometriosis an outlier, or is it just a symptom of being a chronic illness?
Yeah, it does seem that they're across chronic pain more broadly. There are these kinds of similar experiences because chronic pain being sort of invisible, you can't see it. So I do a lot of work with people with chronic back pain that's like non-specific, so you don't have a really clearly identifiable cause, and they do report these kinds of similar experiences of not being believed or being given a medication to manage it. So I'm currently doing a piece of work because I want to look at the differences between those experiences of stigma between people with other chronic pain conditions and endometriosis specifically to do some of those comparisons. I don't know if there's been a direct a piece of work that has compared them, but certainly there are similar experiences across chronic pain, and I do think that's just the nature of chronic pain being quite difficult to manage, difficult to diagnose. So yeah, but I also think with things like endometriosis, there is that added layer of stigma around the sort of the gynecological nature of it.
Fantastic. No, thank you. Yeah, that makes a lot of sense, but I think you certainly get the perception that endometriosis is a bit of an outlier. Again, I suspect related to that stigma. Thank you. Changing tack slightly, and I'll just go to Kylie and then I'll kind of come back to Emma. Kylie, a couple of questions from the chat. One is BMI still the best way to measure obesity, particularly in women, given that it's a male-based metric? And if not, what should we be doing instead?
Yes, really good question, I think, because there's a lot of women that would have a BMI that is classed as being overweight that are actually very healthy, and I think it's thinking about it in the round, isn't it? And looking more broadly than that number. I think there must be work going on. I'm not aware of it in the more medical arena around, you know, how the health being different from just what your weight is. I think hopefully in some of these questions we're asking, we're going to be able to draw out a little bit more around that as well. I'm also wondering if we might get some information about the, you know, Ozempic, Wegovy kind of medication that I wonder if there are, you know, groups of women out there, and that we might be able to pick on that a little bit as well.
Yeah, I think we face the same problems in endometrial cancer, which is an obesity-related illness, and measuring it accurately and knowing what to do with it is a real challenge. But no, I think it's really good. And again, there are linkages there. We could make quite a lot coming up in the chat of people who can see linkages with their own projects or other projects they're aware of, which is all great. That's exactly what we should be trying to do. So we'll try and make the most of that.
Lots of
Emma, just in the last couple of minutes, because it's a really good presentation, really enjoyed that. A question that came up in the chat, which is one that I was also thinking about, is really how do you move from association to causality? How can you cope with some of the potential confounders in your data? So it was really interesting to see that difference between your healthcare workers and your clerks. But could some of that be related to other issues, for instance, exposure to chemicals or exposure to a different working environment, and not just the sort of heavy lifting or heavy aspect of that? And is there a plan to try and overcome that issue? So you're on chat.
Thank you, Richard. Yes, for the medical birth register from Finland, a lot of confounders are already collected. Data on that is already collected. So we were able to control during the analysis. And so most of the confounders, the known confounders in the literature, were considered in the analysis. Yeah, but for the maternity leave, I think there was a question from Amanda about the maternity leave analysis. What we did was to create a dummy variable to cater for countries where conditions are not that favorable, to see whether the results will be significant. And when we did, we created a dummy variable for African countries as a low-income countries to see how the results will be. And still the results were significant. Unfortunately, for that secondary data, most of the confounders were not there. And so we couldn't control some of these confounders because it's a secondary data for the maternity leave.
Yeah, really interesting. And without really big prospective series, that's going to be a real challenge to do. But no, I mean, that makes a lot of sense. Thank you for explaining. Final question, I think, in the last 30 seconds, Kylie. How can women be better informed about the causes of obesity? It's fine dealing with the sequelae of it, but how can we do more about patient information?
I think someone's put that in the chat as well, isn't it? I think it's there's a lot of wider societal issues going on rather than just related to diet and lifestyle. And I think we need to have a much bigger public health push and agenda around supporting people to lead, healthier lifestyles that isn't blamed on the individual. We do need to support, as best as we can, but I think there is a much wider piece of work. Ultra processed food, all of that has a massive impact. I think in Manchester we have people that have complicated and challenging lives, and I think that sometimes has an impact as well.
I completely agree. It's going to need a huge effort, isn't it? But it's got to be very holistic. Yeah. Excellent. Look, thank you very much, all three of you. Can I just now round off the session by formally thanking you all? Those are really interesting talks. It was fascinating to hear a mixture of kind of retrospective and prospective and psychological research, which is all really interesting to sort of bring together. And it sort of highlights, I think, the broad scope of work that is going on in Greater Manchester. And I think we are blessed really to have such a wide range of higher educational institutions and clinical facilities that are now beginning to link together and finally producing some really good work that's going to benefit women and the broader community as well. But thank you for sort of highlighting those three really interesting areas. To everyone else, there is a detail in the chat there of the next two sessions. I can plug the one that Fiona's chairing in a couple of weeks' time, which is about urogynecology and self-use of pessaries, which is really interesting data. I know that quite well. And then my favorite topic is coming up in a few weeks with the oncology one and prevention of cancer. Again, some really good talks there. So if I could encourage everybody to attend those would be both be really good sessions. But thank you today for the speakers, but for you for contributing. The chat has been really interesting. There's lots of good stuff there that people are going to pick up on, and provocative questions which have helped as well. We're only 3 minutes late, which I think is pretty good going considering how much we've got through. So thank you very much to everybody, and I'll say goodbye.